Hey, well, thanks very much. Dr. Weicker gave an excellent talk yesterday that introduced this subject of how we can use laser vision correction as a friendly tool to help conquer the challenges with advanced technology intraocular lenses. And I'll share some of our experiences using this modality. Clearly, we've all evolved into the refractive cataract surgery era where patients want immediacy of outcomes without pain, no stitch, no downtime, and increasingly they feel entitled have this all for no charge. So we've had to evolve, and we've heard some great talks over the last 2 days, including about advanced technology intraocular lenses and how these can help maximize optical performance. And truly, we are fully embracing the refractive IOL era. But with that comes some challenges post-operatively, which I'd like to review together with you, because you can measure chair time in hours and days for these patients, not just in minutes, if we don't take the proper preoperative steps and the careful post-operative management. Why are the patients unhappy? Well, sometimes the surgery didn't meet their expectations, but many times it was because the expectations were unrealistically high from the start. Like us, many of our patients have perfectionistic personalities, so they're difficult to please. It's actually rare that a true error occurs, and then there's the phenomenon, especially when someone is paying out of pocket, for buyer's remorse. So we have to beware that this is sometimes underlying their dissatisfaction. They felt they paid for something that they didn't receive. So we have to understand the expectations, and this actually requires talking with the patient. Sometimes that's the problem, that the patient tells me they never really spoke with their cataract surgeon preoperatively to discuss their goals or what was it that they were really trying to achieve, whether it be distance, intermediate, or near vision, and the frequency and importance of these for their activities. So how can we help our patients postoperatively who aren't satisfied? Well, sometimes it starts with controlling astigmatism. We've had some great talks, and our goal is 0 cylinder. That's what we're trying to achieve so that the IOLs will perform maximally. But enhancing distance vision is often a key step that can be taken to improve the performance of the lens in situ. And certainly of the choices listed here, laser vision correction is really probably our best choice much of the time. Sometimes it's enhancing near vision, and patients have concern of their inability to read, or we've taken away myopia in some of the patients whose brains are programmed as nearsighted. So we can think of the 6 C's of happiness with these advanced technology intraocular lenses and try to work through those. But as was pointed out, it's often cylindrical and refractive error that's really what's causing the dissatisfaction. So if we can correct that, we can convert an unhappy patient into a satisfied patient with the laser vision correction. So Mitch talked about some of the approach, and I'll talk about the actual practice of the laser vision correction, how to best do it for both residual sphere, residual cylinder, and how this may be preferred to intraocular lens exchange or piggyback IOLs. We've had an evolving preference to use advanced surface ablation, which is a modernized PRK, as opposed to actually LASIK, because now you're creating a different surgery in a patient who's already complaining of problems, and we don't want to introduce issues. So to enhance the intraocular lens, the laser can be your best friend. And we're able to perform advanced surface ablation earlier because we don't have to worry so much about the limbal relaxing incisions, or the issues with dry eye are maybe less in some of these patients. Whereas LASIK, we have to watch out for AKs and LRIs. There is a more rapid recovery, but if we're going to do that, we may have to wait at least 12 weeks postoperatively, and some of these patients are very dissatisfied. So what are some of the pearls for performing this in pseudophakia? Well, Roberto Zaldivar introduced the concept of bioptics, where you're combining the intraocular lens along with a corneal procedure, and the pseudophakic can be monofocal, multifocal, or accommodating. The timing of the procedure is important. We have to make sure there's refractive stability so that the effective lens position has been achieved, and that the wounds are stable and not changing over time. Again, LASIK versus surface ablation is something you have to consider for each individual patient, and whether to perform a conventional treatment or a customized treatment, such as wavefront optimized or wavefront guided, come into the challenge. Sometimes it's difficult, though, to capture a wavefront analysis pattern with the multifocal lenses, and if so, therefore, conventional may be preferred to custom. Some of the patients, of course, have myotic pupils, which makes it difficult for iris registration, and aberrations even from the flap itself may change our outcome, and then dry eye and ocular surface, as was mentioned. So the conventional procedure often is sufficient for many of the patients to improve the satisfaction, because usually it's a low amount of residual cylinder, especially mixed astigmatism, that's making the patients unhappy. Be certain that there's a match with the manifest refraction and good correlation with keratometry and topography and wavefront analysis if it can be achieved. And we try to maximize the treatment of astigmatism in our patients who are unhappy. This is the method that we've preferred with the advanced surface ablation, using an epithelial separator device that's been around for a while. That's German manufactured. I have no proprietary interest in the device, but I have been interested in the excellent results that you can get with the epithelial flap left on, as we see here early postoperative, looking almost like a LASIK, even though we've done a surface ablation procedure. Should you scrap the flap or remove the epithelium or leave it, I prefer to leave it if possible, based on some laboratory work that shows that perhaps leaving the epithelium may lead to less haze and stromal opacity postoperatively. Here's the method that you see here with the water jet technique, placing the device, passing the epitome across. And this is engineered so you get a good cleavage just at the epithelial plane, and you do not have stromal incursions with this device. You can peel back the epithelial flap very gently and then perform the procedure. As you see here, this procedure using the Vizx Star S4 system, and then putting a low dose, low concentration mitomycin C for 10 seconds, irrigating, and then the water jet technique to replace the epithelial flap. Have the patient look temporally, and then you can use the jet of balanced saline to replace the flap. Using prednisolone acetate suspension, you can visualize the flap and gently realign it into position, and then place the therapeutic bandage soft contact lens. And with this, we haven't had the dry eye or the haze or scarring and opacity that sometimes can be seen with conventional PRK. Just a couple of cases to finish. A 57-year-old emetrope had cataracts, underwent extraction with the multifocal Restore, was unhappy with uncorrected vision. You see the manifest refraction, just some low residual refractive error equaling 20/20. And what are the options? Well, here's the wavefront analysis with the custom view, and we did a preview lens. The patient was satisfied with the preview lens. So based on that, we performed a hyperopic customized wavefront guided advanced surface ablation. And we can see 5 months out, the patient was 20/20 plus and J1, and we thought, gee, problem solved. But now the patient's very unhappy about the computer vision, the intermediate vision. So the left eye, the surgeon implanted a 2.5 diopter. The patient was sent back to the cataract surgeon. He put in the Restore 2.5. Pretty good results with mild residual refractive error. We did a soft contact lens trial. And what are the options for this patient? Here's the wavefront analysis, matching very well to the manifest refraction. So in this case, we performed a standard, a conventional hyperopic advanced surface ablation with that targeted correction. And fortunately, 5 weeks out, now with the fellow eye, the right eye 20/20 and J1, the patient is very happy with both eyes. And we've taken an unhappy patient and made them happy. So this is a surgeon's tool following refractive IOL surgery to improve satisfaction. And I think it can be something that can be used. We have to remember, why is it that one patient is happy while the other is not? Well, the formula for success is the patient satisfaction is the clinical outcome, which have become increasingly excellent and outstanding, minus the expectation. So if the patient comes in with excessively high expectations, no matter what clinical outcome we have, there's going to be less patient satisfaction. Thanks very much.